It is 12 o'clock, so welcome back to Tips. Hopefully you all had a good last 2 weeks and are getting ready for a lot of rain that's coming to all parts of the state. So hopefully you all stay safe and don't drive down roads that flood. So I'm Rebecca Nevedale with Chappie, and I have two friends with me today. I have Macrina back again. And Macrina, do you want to say hi?
Hi, everyone. How's your day going?
I think we're all those of us in Phoenix are having a sticky day. So, and then we also have today with us Donna Furlong. Donna, do you want to say hi too?
Good afternoon. How is everyone? I'm looking forward to the rain, Rebecca. So
I know it's much better than last year, right? At least we're getting,
yes.
Yeah. So Donna is actually with Banner Health now, but a lot of you Tips old timers who've been around for a while probably remember Donna from when she was at Coconino County, because she did all the Tips with us in Northern Arizona, and sometimes drive all the way down to Tucson. So
yeah, and I was with North Country for a while too, and I see a couple of North Country people on. So
lots of old friends you have.
Yeah.
So today we're going to talk about vaccine administration, and then we're also going to talk about how do you talk with your patients about vaccines. Over the last couple of weeks, you've all been filling out all of those evaluations, and they've been super helpful because we know now what questions you're all getting. So towards the end of the meeting today, we'll kind of just go over those questions and hear those common kind of myths and how you all have those discussions with your patients. So, but first we give out prizes. So on this wheel is everyone who filled out the evaluation, and I'm gonna spin first for our $50 gift card. All right, so Sharon White gets the $50 gift card, and let's spin for t-shirts next. So Shannon Barton gets a t-shirt, one more t-shirt. Michelle Borish. Okay. Well, we are really appreciative of everyone doing those evaluations because we really do use them when it's time for us to plan for the next training. So I'm going to come back to my slides here. All right. So last time we talked about storage and handling. And drawing up the vaccines. But on the evaluations, there were a couple questions. So the first one, I would like further information on how to transport and store vaccines safely to and from off-site work locations to offer TST, which we think is tuberculosis, testing, and vaccines to employees. This can last a couple hours. So what say you, Macrina? Or
Well, first, you cannot transport VFC vaccine. So I'm assuming since this is for employees, it's going to be your purchased vaccine. You can actually go to the, you can use the VFC Ops Guide because the vaccine's the same. And that'll kind of give you some good strategies and some good processes on transporting vaccine. The most important thing is to make sure you have a thermometer in there so that you can monitor the temperature at all times. That's about the best I can, and make sure that you put some barrier between whatever you're using to keep your vaccine cold and the vaccine itself so that it doesn't freeze.
And I think that we found some checklists, so we will put those in the chat from CDC. But the big thing is if it's VFC or COVID vaccine, right? Because that's also private, that's also federally provided vaccine. Your first thing to do is to call the state, right?
Right. And actually the state is being a little lenient with COVID vaccine right now about providers being able to take it out. Because we really are trying to reach people where they are and get them immunized. And if you go to the CDC website and you go to COVID-19 vaccine and information for providers, you can actually just click on whichever vaccine you're working with, Moderna, Pfizer, or Janssen, and you can pull up all sorts of job action sheets that will kind of help you maneuver through the process.
Perfect. So I still need help with the catch-up schedule. So I have a screenshot of it here. What would your tips be on like how to read this schedule?
Well, I think each catch-up schedule is different for each kiddo. So the first thing to do is figure out which vaccine you have, and kind of just pay attention to each one of those columns. Which vaccine do you have? What was the minimum age of the first dose? And then just pay really close attention to each specific interval, minimal interval for each vaccine that you're administering. And that's probably the easiest way to do it. It is a little complicated. And I don't know, Donna, do you have any good hints? You've seen a lot of catch-up schedules.
Yeah, I think my takeaway when I try to do a catch-up schedule is don't rush it. Don't think that you're going to wait till that patient is in the middle of their 15-minute visit to try to figure this out. If you can do it ahead of time or let them know it's going to take you a little bit of time so that you're not rushing through this, because if you do, you're going to miss some little nuance of it, and it can be somewhat confusing. But just slow down and really read each one of those columns and make sure that you're in the right column and looking at the right minimum spacing.
That's a really good tip. So it's a good thing to do when you're doing your chart prep. If you're not sure, make sure that you ask somebody else. It's okay to ask questions. And if everyone is stumped and can't figure something out, remember CDC has that Ask the Expert function where you can just email. And if somebody, one of the TAPI folks wants to Google Ask the Expert and put that link in the chat, that would be great, because they really do. Typically, it's an email that you email your questions and they typically get back to you within the amount of time that like the patient's still in the exam room. So they're usually pretty fast. All right, so vaccine administration. You have successfully gotten your yes from your patient or your parent. You've prepped the vaccine, you've gone into the room, you've washed your hands, and now it's ready, you're ready to administer. So remember, the reason why appropriate administration technique is so important is, well, one of the big reasons is that it reduces your risk of disease spread, right? So you don't want to get poked with a needle. But also it's important that vaccines are given sub-Q if they're sub-Q, IM if they're IM. But let's first talk about how to protect yourself with comfort holds. So talk to us about the babies, Macrina.
Oh, it's really important because parents are sometimes just really nervous, and they're really nervous about those brand new little babies. We just don't want to make them cry. And so I think the most important thing is just to teach them how to hold them, give them a nice strong hug. And so that you are safe, the baby is safe, and mom is safe. So that's probably the most important thing, is to make mom feel comfortable by telling that mom how to give that baby a real nice, strong hug. And then make sure you get access. I like both of these pictures. They're both different holds, and it's which hold is you're most comfortable with.
And can mom breastfeed?
Totally, mom can breastfeed. She can breastfeed. She can also feed the baby when they're getting immunizations. And the good news is some studies show that it actually decreases crying and that it may decrease pain. So it's definitely a really good idea to let mom breastfeed or feed the baby while you're immunizing.
And there's a question, and well, Jennifer's saying, can I have a copy of these pictures for the exam room? That's a really good idea. We'll make sure to send the slides, but if you also want us to just create the pictures, we can do that too. So we'll follow up with you. And then there's another question that their clinic says they don't have to use gloves, which is true. OSHA does not require gloves, but sometimes it makes the patient nervous. How do you handle that?
So we don't wear gloves either, and our organization doesn't require us. We try to explain to the mom or dad or the patient that the gloves are really to protect me. There really is no protection provided to the patient for me wearing gloves. On the other hand, if they feel more comfortable, I will put gloves on, because my goal is to get people immunized. No, I don't like wearing gloves. I will put them on.
Donna, do you have anything different that you would say, or?
So I'm actually the opposite. I like to wear gloves when I do vaccines. So I think it's just going to be whatever your practice is. But McCreen is right. The protection is for me, not for the patient. So it shouldn't make them nervous. But if it makes you nervous, then I would recommend the same thing for you. If you feel more comfortable wearing gloves, and it's okay, your organization might absolutely do that. Because you need to be comfortable, the patient needs to be comfortable as much as you can be when you're about to hold a short stick.
Right.
And that's true, because we do have nurses who feel more comfortable wearing gloves.
Yeah. All preference. Okay, so that's our little itty bitty babies. And I think it's funny that parents don't want them to cry, because isn't that just kind of what those little ones do the whole time? So, but then when we get to toddlers, here we're also looking for flailing arms and legs. So talk to us about holding the bigger babies.
Right. So the goal is to keep the limb that you're actually giving vaccine in and hold it firm. So both of these are techniques that you could use to hold babies. You could also hold them facing forward and the legs between the parent's legs. This shows both sub-Q in the arm and then in the vastus lateralis on that little kiddo there. And again, I always tell parents that it's a good thing what they're doing. They're protecting their babies. So the mom who's kissing his top of his forehead is just something you like to see. Make moms feel good about immunizing. Okay, this is these kids are getting a little bit older here now, so it gets to be a little bit more of a challenge, a little bit more of a workout. They know a little bit more what's happening. But again, it's all about, we call it comfort holds or comfort hug. I think the most important with this age group is just to let the moms know, don't let go until I say let go. Okay, we're all done. Because sometimes moms and dads will, once you get the needle in, they'll like, okay, well, we're done. That's only half the battle there, guys.
And the only thing I would add to that is watch the siblings in the room. I had a mom who did a fabulous job controlling the patient I was trying to vaccinate. But as soon as that kiddo started crying, his brother kicked me because I was hurting his brother.
Oh, that's a good brother.
Yeah. Okay, and I'm sure you all know this, but so we have subcutaneous. It's going to go in at a 45-degree angle. We definitely want to get it into the fatty tissue there. It's usually the back of the arm is the best place to go. Some of us have a little bit more back there than others. But you can always find something right between the elbow and the shoulder. And then the IM, you're going to go in straight at a 90-degree angle. You want to make sure that you use a long enough needle so that you actually do get in the muscle tissue. So don't be scared if you have to up it to 1.5 inches for the older adolescents or teenagers, because you really want to get that vaccine into the muscle. If you're going to give 2 in the same deltoid or the same vastus lateral, you need to separate it by 1 to 2 inches. Okay, here's just a picture of where those muscles are. If you can see on that infant and toddler, If you bend to the knee, you can really see that muscle pop, and it's pretty easy to aim for. And again, with the older children, 3 years older and adults, you're going to give it right there in the little triangle there, the deltoid. Make sure you do go below that acromion process, because that's going to cause your patients a lot of pain and suffering if you get it too hot.
And how are you finding that? You feel around?
You feel around, I don't know, I'm touching my elbow here and y'all can't see it, but you feel around and then you just go a few fingers down and you'll be able to find it.
Okay. There's some comments in the chat there about comfort holds for older kids, and I'm sure we've even had to do them for some adults before.
There's some 11 and 12-year-olds that I ask, hey, do you want to sit on mom and dad's lap? And then they kind of help and just kind of give them a nice little hug, kind of assurance. I have no problem having a 16-year-old sit on mom and dad's lap if that's what it needs. Do whatever is safe. Yeah, do whatever, make sure you are safe. I mean, I think that's the biggest thing when we talk about vaccine administration. You want to make sure that you are safe as well, because you need to take care of yourself. So always make sure that you're not going to get hurt or get a needle stick.
And even for adults, they get scared too. And when we started giving COVID vaccines, I cannot tell you the number of people whose hands I held while somebody else gave them the vaccine. But as adults sometimes can do much better with comfort holds.
Right.
Mm-hmm.
Appropriate ones. I like that disclaimer. So here's all the vaccines that go sub-Q. Here's all the ones that go IM. This is a graphic from CDC, and they have not added COVID-19 to it yet, so we did that for you. And there was a question a few weeks ago about, are you supposed to put some vaccines in the left arm, some vaccines in the right arm? You know, this is Maricopa County's document for that, which also has not been updated yet for COVID-19. I guess you've been a little busy giving the COVID-19 shots, but.
Yeah, we follow a standard, which vaccines go on the left, which vaccines go on the right. This is just our policy and something we have implemented. Definitely no requirement by anybody. But like we've always talked about in the past, the more you have put in place, the more structure you have, routinely the less chance there are to have holes in those processes so that errors don't happen.
Mm-hmm. Yeah, so if your organization might have something like this, and follow it, and if you have questions or you think this doesn't make sense, ask those questions of your supervisors. So we have the oral vaccine is rotavirus, Rototec and Rotarix are the only oral ones right now, right?
Correct.
Yep. Anything,
that's it.
Don't put a needle on this. It's not one of those kinds of vaccines.
Don't put a needle in it. We always we give it first. It's a little bit easier before baby starts to cry. But again, it depends on what you've had success with. And it's pretty simple. I would always recommend a little tissue or something, so in case they spit anything out, you can catch it. Yep. Intranasal, Flumist. And that's about the look that they give, that don't make them lay back. Don't put their head back. Don't take a big sniff, nothing like that. Just sit there, a little up one nostril, a little up the other nostril, then you're good to go.
And this is not Afrin. They're not supposed to be.
Right, they're not, don't have them take a big snort or sniff or whatever, I don't know what to call it. Don't lay them down on their back. Don't have them put their head back. Just sit there normal in the chair, just looking at you.
And Macrina, don't you want to angle it towards the outside of the nair as well, so it hits the mucosa?
Correct. And you also do not want to go too far up. It works best right there in the middle of the nose. You don't want to, drive it all the way up.
Yeah. Oh. Let me make sure I didn't miss something. I don't think I did though. Okay, so this is So this, oh, let me make sure I put the sound on. So this is a video that is administration for adults. So we'll watch this.
Hi, I'm Kristen Park, Public Health Nurse with the Maricopa County Department of Public Health, and today we'll be doing a quick overview on how to give an IM injection. First, we'll review the process using a pre-filled syringe and a safety glide needle, and end with reviewing the same process using a Vantage Point retractable syringe. Let's begin. Hi Jenny, how are you? First, identify your patient and explain what vaccine will be given and which type of injection will be done. If it's within your scope of work, screen for contraindications and verify that your patient has received a vaccine information statement and has had time to review it and ask questions. Perform proper hand hygiene prior to preparing the vaccine. Gather the appropriate supplies, including the correct needle length and gauge, sterile alcohol, and bandage. Verify that you are removing the correct vaccine from the box and check the expiration on the syringe. Pick up the pre-filled syringe and make sure there is no discoloration or precipitate. Next, remove the needle from its packaging. Be careful not to touch the hub of the needle. Hold the needle by its protective cap and attach it by twisting it onto the tip of the syringe. Remove the small amount of air in the syringe and recheck the expiration date and vaccine. For an IM injection, the deltoid muscle is the preferred site for adults. Identify your injection site by having the patient relax their arm. To locate the landmark for the deltoid muscle, expose the upper arm and find the acromion process by palpating the bony prominence. The injection site is above the level of the armpit and approximately 1 to 2 inches below the acromion process. Now, clean the area with alcohol and allow the site to completely dry. Control the limb with the non-dominant hand. With the dominant hand, inject the needle quickly into the muscle at a 90-degree angle. Inject the vaccine using steady pressure and withdraw the needle at the angle of insertion. Make sure to activate the safety shield immediately after removing it from the patient. It's important to activate the safety shield away from self and others. Finally, after properly disposing the needle and syringe in the sharps container, you can apply a bandage, perform hand hygiene, and remember to document injection site and procedure per policy. Now that you've seen how to give an IM injection using a pre-filled syringe, let's see how this process looks using a Vantage Point syringe with a single-dose vial. First, identify your patient and explain what vaccine will be given and which type of injection will be done. So today you're getting a Tdap vaccine. If it's within your scope of work, screen for contraindications and verify that your patient has received a vaccine information statement and has had time to review it and ask questions.
No, not at all.
Perform proper hand hygiene prior to preparing the vaccine. Gather the appropriate supplies, including the correct needle length and gauge, syringe, sterile alcohol, and bandage. Verify that you are removing the correct vaccine from the box and check the expiration on the vial. Next, check to make sure there is no discoloration or particulate matter. Remove the protective cap and clean the stopper with a sterile alcohol wipe. Carefully open the needle and syringe and remove the cover from the needle. Hold the vaccine vial with your non-dominant hand and insert the needle straight into the center of the stopper. Pick up the vial and syringe together and invert them. Hold the vial and syringe at eye level and carefully pull the needle down so the tip of the needle is in the liquid. Withdraw the vaccine by pulling on the plunger and removing all contents of the single-dose vial. Carefully recap the unused needle and tap gently on the syringe to release any air bubbles. For an IM injection, the deltoid muscle is the preferred site for adults. Identify your injection site by having the patient relax their arm. To locate the landmark for the deltoid muscle, expose the upper arm and find the acromion process by palpating the bony prominence. The injection site is above the level of the armpit and approximately 1 to 2 inches below the acromion process. Now, clean the area with alcohol and allow the site to completely dry. Control the limb with a non-dominant hand. With a dominant hand, inject the needle quickly into the muscle at a 90-degree angle. Inject the vaccine using steady pressure and fully depress the plunger to activate needle retraction while the needle is still in the patient. Finally, after properly disposing the needle and syringe in the sharps container, apply a bandage, perform hand hygiene, and document injection site and procedure per policy.
Thank you.
We just watched 2 different methods on preparing an
All right. Thank you, Kristen Park. So a couple things on that video. So one thing that we noticed, especially during COVID, when we were all combing over VAERS, is you saw on that first model, it was a short sleeve shirt, and that is easy to kind of just roll up really quick. But if it's a long sleeve shirt, we don't want to roll those up, right? We want to have the patient remove their arm. Isn't that correct?
You definitely want them to remove their arm from the sleeve. And it doesn't matter where they are in the org chart. I had the chairman of the board of supervisors take off his tie and his long sleeve shirt to get his COVID vaccine. It's safer, it's more effective, it's going to be less painful, you're going to give it more appropriately. So just always make them take the time to take off their long sleeve shirts, and don't roll them up if you can't get into the deltoid.
Okay. And then another comment in the chat box about gloves. So gloves are not recommended by OSHA, but if your agency or your clinic recommends them, please make sure to wear them. And we know that that can be preference too. So let's talk about reactions.
So with every vaccine, there is a typical normal reaction that you're going to get. With your Tdap, your arm's going to be sore. All of you who listened to me on tips before with your shin grits, it's horrific as far as I was concerned. But so there's a lot of things that are routine. Localized, you see quite a bit, some soreness, redness, a little bit of itching, maybe a little swelling at the site. You might see a little bruising or a little bit of bleeding. Then there's some psychological sort of issues that happen, and we know that a lot of those are to our adolescents, where they get some paleness, sweating, nausea, dizziness. I'm sure y'all can know the look of a 11 or 12-year-old that's going to pass out on you, don't you? Sometimes they fall, sometimes they lose consciousness, sometimes they don't. You just want to make sure that that's why you have them sit for a while. And then there are some systemic, where you're going to get some fever, some body aches. You're just not going to feel 100%. I wish loss of appetite came after my Shingrix vaccine or my COVID vaccine. But I use food to make me feel better. A lot of these are really normal. So the whole idea is just to make sure and let your patients and your clients know what to expect, what is routine and what is normal. And a lot of times, if you do that ahead of time, it just prepares them. It's going to decrease a lot of phone calls to your organization. And a lot of time when I warn people what we might see following vaccine, if they get nothing, they feel like they won the lottery. I had nothing. Mm-hmm. So just always give them the information that they need so that they know what to expect.
The one thing that we've heard at tips before is that a lot of times people do the MAs or nurses or whoever's actually administering that vaccine does this coaching, especially for parents and new time parents after the vaccine has given, because anything that's done before, especially for first time parents, they're really not hearing you. Right. They're really nervous about the vaccine, that they just don't want to break that new baby. So timing of that conversation is really important.
I think, Rebecca, the other thing to keep in mind is a lot of times people think because they had this kind of reaction that they are somehow allergic. Mm-hmm. And these are things that we expect to happen. It's your body reacting to the vaccine. It is not your body telling you don't ever do that again.
Yeah, so it's not an adverse reaction. It's a typical.
Right.
You're
right.
This is an adverse reaction. That is not something we expect would happen. That's a little significant, right?
That is definitely significant.
And especially if that picture was taken right after the vaccine was administered in a clinic, that would be very significant.
Very, very significant.
So that's when you would report to VAERS. So remember the vaccine adverse event reporting system. Anyone can submit a report to VAERS. A patient, a parent, Macrina had a 12-year-old once who thought his arm was just a little too sore. She's told that story many times and said, go ahead, report it to VAERS. This is a monitoring system that looks for trends. So if you've ever reported to VAERS, and it's something that does pop up and is going to be investigated, you'll get a phone call from CDC. They'll ask for lot numbers and some more information. But anything else about VAERS, and all of that is public too.
Right, and never ever be afraid or fearful or anything with the VAERS system. It's just reactions are reactions. They routinely 90% of the time have nothing to do with how vaccine was administered or anything. It's just how somebody reacts to a vaccine. So just if you fill out a VAERS whenever you feel you need to, or whenever a patient, sometimes patients just want one filled out, and I can do that for them as well. But if it's significant or something to follow up, then you will be notified.
Right. And we have a poll that popped up and would love to see your answers. But if you are selecting yes, that you've seen an adverse reaction, we'd love for you to chat in what the reaction is that you've seen. Have you, Donna or Macrina, ever seen an adverse reaction? Not a typical reaction, an adverse reaction?
I actually saw one that looked similar to that picture you had.
Oh, did you?
Yeah, and it was somebody had misread how to give the PPSV 23, the pneumo 23, and given it monthly. And the second vaccine caused her to have that kind of a reaction.
So is a hive or hives an adverse reaction?
Absolutely.
Yes.
That's an adverse reaction. So if it's at an injection site for MMR, that might actually be a measles, right?
Right.
Yeah.
Which would be a typical reaction.
Well, sometimes with varicella, you might see a little varicella vesicle at the site of injection, but you normally don't see that with MMR.
Okay. Is fainting an adverse reaction?
No, not an adverse reaction. The majority of time, fainting usually has to do with more of an emotional reaction. Usually we see fainting in our clinics. It's usually the adolescents. It's usually they haven't really eaten. They've gotten really worked up. They've gotten very nervous. And it's usually the quiet ones that pass out. The ones who come in arguing and fighting and that usually don't pass out because they've gotten all those emotions out.
Right.
It's those quiet ones that are going to sit down and just take it. And then all of a sudden, the next thing you know, they're pale and you're having to catch them as they go to the floor.
I saw quite a bit of fainting at COVID clinics. And then once one would go down, then a lot of people would go down, but typically it was anxiety.
Mm-hmm. Oh, and
Preemptive.
fainting is very contagious.
Yeah.
If you're doing adolescents or even adults, you see one pass out, then you're going to start to see more and more.
Yeah.
And anyone who's done a mass immunization clinic can attest to that.
Is cellulitis an adverse reaction?
Yes.
Okay. So cellulitis is so that would warrant a VAERS report. Hives would warrant a VAERS report.
If in doubt, fill out a VAERS report. I think that's always the best thing to do. Let the scientist figure it out, whether it's a true adverse event or not. If in doubt, fill one out.
What's COVID arm? Have you guys heard that phrase? I've seen COVID arm.
My arm was really sore after my second dose, but I didn't get any swelling or redness or anything, but some people did. I had somebody who got a really big welt like 7 to 10 days later.
I did. In fact, we thought it was cellulitis. We even started to measure it. But I think it was just the welt.
Yeah. I had somebody who had a really big welt. I couldn't move my arm for 2 days afterwards.
Yeah, it's interesting that people are agreeing. Oh yeah, it's always the quiet ones.
Yep.
I think that we have to be careful with how we, when patients come in saying, I don't want an adverse reaction, just kind of leveling those expectations, because a true adverse reaction is incredibly rare. That something really out of the ordinary would happen is incredibly rare. There are things that are ordinary, like fever, like, fainting, I guess, could be considered ordinary. Sore arm could be considered ordinary. There are things that are ordinary that happen, but those are not adverse reactions. So I think it's just we've gotten a lot better in talking about immune response with COVID vaccine, but be careful to make sure your patients don't think typical reactions or adverse reactions. They report it to VAERS, they report it to VAERS, that's okay. It's a monitoring system. The scientists work it out. But just for vaccine hesitancy in general, we need to be really careful how we talk about this, I think.
Yeah, and be empathetic too, because just because it's ordinary doesn't mean everybody has it. So just because you didn't have it doesn't mean that your patient didn't have it. So we got to kind of balance that and take them seriously with what they're telling us, but also measure it out. Like if they got redness, but it was only around the size of a quarter, I'm way less concerned about that than if it's the size of the palm of my hand.
Mm-hmm. All right, and what do we have to document is the date administered, the manufacturer and lot number, the date the VIS was provided, the VIS edition date, name and title of who administered, and address of the facility where the record's going to be. Those are required, right?
Correct. And you also, best practices, and really what you should document as well is the expiration date and the route, site, and dosage. And you should definitely document whether it was left or right deltoid, or right or left vastus lateralis. It really does help if you really do have one of those adverse reactions that you need to report. You really do need to know what limb it was given in.
Where it's And we also, make sure you document your refusals. A lot of practices use a patient refusal form. Do you all use those?
We do.
We do as well.
This is a really important tool because remember, not every refusal is going to stay a refusal. So it's an important tool that if you document that at every visit, every time that, if you want to offer vaccine at every visit, you want to document the refusal at every visit. It just helps create a system that's going to help that patient consider, the option of vaccinating again. So, and obviously you document that in the chart, and they can document it in ACES as well, correct?
I do not believe you can document refusal for vaccine in ACES. I think all you can document in ACES is a contraindication. I don't think you can document refusal.
Okay, and Jen just put a AAP's refusal form in there. So anybody have any administration questions, anything else? Oh, Jennifer's saying you can document exemptions in ACES.
Right.
That's probably, in my brain, that's what that meant, yeah. So
right, but to keep in mind in ACES, if you're the one, if you are the provider that documents exemptions in ACES, you're the only one who can remove that exemption in ACES if they opt to get the vaccine.
Okay.
Remember that exemptions is usually something we use to attend school and childcare so that you exempt yourself from receiving those required vaccines.
So obviously we all wish that every patient or parent who could get vaccinated did get vaccinated. That's not the case, but we want you to remember that the research shows that most people are not adamantly opposed to vaccination. Most people just have questions and need those questions answered. So we want to make sure that you don't look at every question as an all-out refusal or think that person is automatically anti-vaccine. So we always keep that in mind when you get asked questions, that your ability to answer those questions and let that person feel heard is really going to be able to help them make whatever they think is the best choice for them and their family. We have gotten lots of questions on the evaluations and in the chat boxes. So we're just going to kind of go through some of those and see how Macrina and Donna answered these kinds of questions. So the first one that we heard you are hearing a lot is, isn't it better to get natural immunity by getting the disease? And this is really big with COVID. So how do you guys address that?
So for me, I usually start out with talking about the risks of the disease itself. And the one thing about especially COVID, we don't know why it affects one person tremendously and barely even bothers another. We don't have any idea what causes that. So I can't look at you, Rebecca, and say, you know what, you're going to be one of those that has a super bad reaction. You should get this vaccine. And then look at Macrina and say, oh, you know what, you're going to be fine. Don't worry about it. So that part is really important. But then we also need to remember that by vaccinating ourselves, we're caring for our community. And I think that that's something that sort of gets lost in this conversation, is that we do need to take care of each other. My community is important to me. I want them to be healthy. So I get vaccinated with a flu shot every year because I want to keep my community healthy, my grandparents, my parents, my close family.
It's, and with COVID, I think that's probably been one of our better education techniques primarily, is when you talk about adults who really would rather just wait. But if they have young children who are unable to get immunized, then it's about protecting them and those around you. And I can't, even when we talk about measles and mumps and rubella and the other vaccines, there's no way to tell what the severity of the disease that you're going to get. There's no system in place. So it's just always better to get the vaccine than take a risk on what your outcome is going to be with natural disease.
And if you have any other things that you all say, please put them in the chat, because we know this is something that you hear a lot. Anita's saying she also uses that herd immunity angle. So this is about protecting your family and the community. The flu shots, like this, I think that for those of you who are especially in primary care, offering flu shots for months and months and months at every single visit that you see these people, you hear all the time, why I don't need that. I never get the flu. Last time I got the flu shot, I got the flu. And there's so many common myths with flu shots. So how do you talk about flu?
Well, with flu, I just jump right in and say that, flu just doesn't get the respect that flu should get. I think a lot of people think that every time they get the sniffles, or they get a sore throat, or they get a cough, or they get some or allergies, or anything that happens from October through about the end of March is the flu, regardless of whether it's GI or respiratory or the sniffles. And the flu is a severe illness. I mean, you're down and out for a couple of weeks. You have high fevers, body aches, chills. People get hospitalized with the flu. So when they say they got the flu from the flu shot, I routinely ask, what were your symptoms? Because in a lot of cases, it wasn't the flu. I don't know, Donna, I'm stymied with the why should I get a flu shot because I never got the flu. That's a tough one for me. That's a tough one for me to work through.
Yeah, I have the same reaction, and I actually have a family member that tells me that all the time. And I think my immediate reaction to them is, you are so lucky. I'm so glad that you didn't have that. But still, one of these days your luck is going to run out. And so please get your flu shot. I mean, the best you can do is just be as honest with them and forthcoming with the information. Answer their questions honestly. Don't lie to them. Don't say, oh, nobody ever has an adverse reaction from the flu shot. That's not true, but it is rare. So be open and honest with them, but also be compassionate and passionate about what you're saying. Don't say, well, you really should. I go the other direction. I tend to be a little more zealous, and maybe I'm too zealous. I don't know, but I really try to talk about, the flu virus can't reproduce in a way that's going to give you the flu vaccine, is not going to reproduce in a way that can give you the flu. So that doesn't work. But the people who get the flu, even though they got the flu shot, that's usually the one I have to combat. What we do know is they get it. The flu is less hard on them. They have fewer symptoms. They're not often as hospitalized, and they very rarely die from the flu because they have that shot that helps their body start to learn how to fight it.
And yeah, the flu shot itself is not a live virus, right?
No. It cannot, the flu shot cannot cause the flu.
It's interesting too, well, every time I get the flu shot, I get the flu. A lot of times you're not getting it every year. You're typically only getting it the years where we have a really scary strain out there and we have a ton of messaging and a ton of opportunities and we're really hitting you with it, which is what's making you probably get it those years because we knew you were probably going to get exposed. So, yeah.
And I also think that sometimes as people wait until a lot of folks say, well, I'm just going to wait until it, the flu is really bad out there, and then I'll go out and get the flu shot. So if you wait, especially in Arizona, if you wait till like January, then most likely you're going to be exposed to the flu because it's widespread. It's everywhere. So the later you wait to get the flu until it's widespread, there is a chance you're incubating the flu when I give you the flu vaccine.
Right.
Yep.
The best time to get it is always get it, October, early November, before it becomes widespread.
Right. Yeah, Teresa's saying in the chat, yeah, those people are the ones who've never really had the flu. So I think that goes back to what you said in the beginning, Macrina, because the flu is not you're back at work in 2 days. So
Right. I just don't think the flu gets the respect it deserves.
yeah.
Agreed.
So our next question that still keeps popping up, do vaccines cause autism? How do you talk to parents about this one?
Gosh, you know what? I don't go, no, it does not, which is what I want to do all the time.
Only in our heads, only in our heads.
Only in our heads. Again, I think you're just compassionate because they heard it from somebody, either from a friend on social media, and they're just asking a question.
Yeah.
You got to remember that a lot of us live this, breathe this every single day. And that a mom with a new baby probably really hasn't put much thought into it until they show up in your office. They've just heard a lot of information. I just say, there have been multiple studies over time that have disproven vaccines cause autism. They have proven that vaccines do not cause autism. And then I talk about Autism Speaks, and a lot of these organizations that work with children who are autistic, they want this discussion to stop because the more we continue to study autism and vaccines means that we're not putting money into actually trying to figure out what does cause autism. And so when I say that those organizations that actually care for, treat, and work with families and children who have autism want this conversation to stop and believe that vaccines have no role in autism because they really want the real reason, the real cause of autism to be studied.
I think that's a beautiful point. You said it very well, Macrina.
And I think that's what they want to hear.
Mm-hmm.
So how do you know they're safe?
I think that vaccines are probably the best studied public health initiative in the world in our lifetimes and ever since, Jenner. We study these ad nauseum. We take so much data on our patients who have vaccines, who don't have vaccines, and everything in between. They're just so well studied. And again, we know they're not 100% safe. There's not a medical treatment out there that is, but so much safer than getting the diseases.
And remember when we talked about the ACIP and how they continue to meet and they look at disease trends, they look at vaccine rates, and they see how do they interact. They take a look at the adverse event reporting. They always talk about adverse events and take a look at that information. So this is, of anything that's ever done in medicine, this is one thing that they review all the time.
And we also, when we talked about this before, talked about how old some of these vaccines are. I mean, the vaccines have been around for a really long time. So,
I always like to say I'm 57 years old and I got polio, I got MMR, I got all these vaccines. Now granted, and they've been made safer over time. They've been studying the schedules that long. And yet I just told everybody my age.
So they,
But I think that for some people, that's part of the problem, right? They see HPV and COVID as being so new, but they need to know that they're very well studied as well. We may not have as many, the 10 years of data since Macrina was itty bitty.
That's true.
But we do have data on it, and we continue to gather data, and recommendations are looked at multiple times in a year to make sure we really are doing the right thing for our patients and that these are remaining safe.
how are you? One of the things that we've bumped up against a little bit is some groups that don't have a lot of trust in the government oversight of vaccines and things like that. How do you talk to those people about safety? I think our go-to is always, oh, they're so studied, it's so regulated, How do you talk to those people?
Sometimes that's at the point where you just need to sometimes be really honest with folks, because I have to tell you, those are probably the hardest conversations to have, are those who don't trust the government, who don't trust me because I work for the county. But just to talk about, I immunize my own family. I love my little second cousin Amelia to death, and I had a long conversation with their parents about how safe HPV vaccine is. I immunize my own family. And I think that sometimes that's okay to say, because that it's okay to say, builds confidence that I immunize my own family. I encourage them. I'll have those discussions.
Yeah, I think that is to always remind people that, well, it was safe for me that I decided, is really powerful for people.
I can't tell you the number of people who asked me out at the COVID sites, did you get the vaccine?
Yeah.
Yeah, I did. And it was really helpful for me to be able to say absolutely as soon as I could.
Yeah. So a lot of this is especially with parents, we hear, but don't you think they're getting too many shots too soon? I want to spread them out. It's just too much for their little bodies. How do you address this?
So for me, I always go back to my favorite infographic that we put out every year on tips, which shows, the number of antigens I got, because I'm not a whole lot younger than Macrina, versus the number that we give now. And when Macrina and I were getting vaccines, we could only cover, about seven diseases. And now we can cover 14, 15 if you count COVID. And there's less antigens in all of those vaccines put together than there were in the 7 that we got in our childhood. So the other thing you have to do this gently and carefully. So the way I say it is probably not the best way, but the minute that baby comes out of the womb, they're exposed to way more things that could hurt them and challenge their immune system than what we can give in any amount of vaccine.
You know what? That's the exact same thing I use, is that the minute they come out of that environment where everything is like just clean and sterile, that they become exposed to the air and to dirt, and then they start to crawl on floors and everyone holds them and the air is filled with so much that they're exposed to so many things that the body actually builds a response to.
And then they put everything in their mouth.
Right. So kind of when you explain it that way, I think it's parents sort of say, oh, okay, I get it. And, and I think when we start having the discussion about spreading them out and there are too many, and I'd like to, have a different schedule, I think there's risks to that as well. And I think that that's sort of the conversation you need to have as well, is that, okay, so you want to spread them out, but remember that if we spread out, vaccines that are supposed to be given within the first 6 months over 12 months, that then, your child is going to be susceptible to these other diseases. So I think sort of there's a risk in not immunizing with everything you need, as well as the perceived risk they have with getting vaccines.
I've had some success too with saying, you know, if we spread them out, then that means every time they come to visit here, they have to have a shot. And that can cause them to be afraid of the doctor. And then later in life, they may not go to the doctor when they need to. I've had some success with that.
I think there has never been a more critical time for you all to know how to talk with parents of young children about how the schedule is studied and the importance of adhering to that schedule. Because I mean, you've been in your clinics the last year, you see your volume is down and our immunization coverage rates are suffering. So we really need to be vigilant about getting not missing any opportunities with these young kids, so we don't have measles outbreaks and other outbreaks that we're combating in upcoming months and the year.
And also sometimes keep in mind that it's not necessarily the number of vaccine itself, but it's the number of needles and pokes. So kind of figure out which one it is. Because the number of vaccines, that's a little bit more challenging. But if it's a number of pokes, that's a little bit more easy to sort of talk through. So kind of figure out which one it is that is really concerning them. Before you start explaining getting all these vaccines is safe, and really what they're more concerned of is there's going to be 3 pokes, not that there's, 7 vaccines.
Absolutely.
Yeah. So next, when we meet in 2 weeks, we're going to talk about best practices that offices use to get 90% of their whole population covered. But we're also going to spend about half our time on August 5th talking just about COVID. So we're going to give you an update on Delta variant and some other things that are bubbling on our Facebook feeds and in our emails too. And we're also going to spend some time talking about those common objections and myths that we're hearing about COVID-19. So when you do your evaluation, please make sure that you tell us what you're hearing, and go ahead and throw them in the chat too, so we can make sure that we give you good talking points to address COVID-19. So whether it's COVID or it's regular old vaccines, here's just a couple really to sum up some tips. The first thing is that the research does show that presenting vaccines as the default option is the most effective way to get patients immunized. So when that patient checks in at the front desk, when you're doing your vitals, when you go into the exam room, saying to the patient, today you're receiving 3 vaccines. Today you'll also be getting your flu shot. Assume that the parent or the patient is going to want their vaccine from the get-go. If they have questions, we'll make sure to ask them of you. And when they ask their questions, if they do have questions, make sure that your patients really feel heard. And, Donna, you talked about this, Macrina did too, but sometimes you're getting these questions and you really want to scream, no, not again. But for young parents who haven't had to think about this a lot, this whole thing is really new to them. For older patients who haven't gone into an office in a long time and haven't gotten a vaccine since they were a kid, this is a lot to think about. The first thing out of your mouth after hearing a concern should make that patient feel heard. So saying something like, I hear you right away, or restating what they already said is really important. Making sure that you say to them, a lot of other patients have asked me that same question. If someone says to you, oh, last time I got the flu shot, I got the flu. I'm really sorry you felt so awful when you got the flu. So make sure that you corroborate. The research also shows that you must give your strong recommendation. So saying the words, I strongly recommend you get these 3 vaccines today is really important. And also, just like what Macrina was saying when we were talking about folks who don't have trust in the oversight of the vaccine process, sharing your personal story and saying, I believe so strongly in this that I got my own daughter vaccinated for HPV at her 11-year-old well visit, or I believe so strongly in this that yes, I did get my COVID-19 vaccine. We also want to remind you again to be honest. We are so excited you're so pro-vaccine and want to say and do everything to get people protected against these diseases. But we have nothing to hide in the world of vaccines. Science is on our side. When patients say, is it possible that she could get an adverse reaction? The answer is yes. It's very rare, but yes, it does. And if you don't know the answer to a question, just say, I'm really not sure about that. Let me tell the doctor or the provider and make sure that they talk to you about that. So, and never give up. Your no, the no that you get from one patient could be the next MA's yes. I just did a COVID vaccine clinic a few weeks ago, and there was a nurse there that was talking to all of the people at this. It was a really small church with a lot of refugee communities that go to this church. The nurse talked to all of them, answered all of their questions. Many people said yes to vaccine that day. Many people said no. When we went back 21 days later for the second dose, we had 20% more people get immunized. So they got their questions answered at that first visit. They went home and thought about it, and they changed their mind. So please just don't give up. Always keep having all of these conversations. So we will definitely see you all on August 5th. We'll keep the line open for a little bit just to make sure that we get any other questions answered, but have a good next couple weeks. And let's dig through these. We have lots of fodder for August 5th for COVID-19. Okay, Macrina, there was one that I'm not sure if Jennifer got to or not about how do you immunize when someone is on a tube, I think. Did you see that one?
You know what? I don't know the answer to, so they're on an NG tube. I guess the question would be, is the kiddo nothing by mouth? But routinely we've seen kids in clinic with NG tubes, and we go ahead and just give it routinely like we normally would, as long as there's no contraindication.
Does the vaccine work by getting into the vessels in your mouth? It doesn't have to be injected.
Primarily, right. It doesn't, it's not that it gets all the way down to the gut.
Okay.
Yeah.
So Amy, we'll make sure to look that up too.
I'll look that up to confirm it though. Yeah.
Flumist is a live virus, correct?
Correct. It's live, but it's attenuated. So it can't cause disease, even though we have heard some folks say that their throat got a little scratchy afterwards. I see one about somebody starting an HPV at, so if you start your HPV at 11, you get your second dose at 22, then you should be complete. You do not need a third dose. It's all about when you initiate, when you start.
It's as if you start, when do you need a third dose? When you start at what age?
Ooh, is Donna still on? I believe.
We'll check.
We'll check.
15.
15, okay. See, I don't get a work clinic all that much anymore. I have to have those little cheat sheets next to me.
Well, that everybody should have one anyway.
I have to have those cheat sheets next to me all the time.
Any news on approval for Moderna? Where is that? When is that going down to age 12?
We have no idea. We keep asking that question every single day, why they haven't looked at that, because I think they went to the FDA well over 6 weeks ago.
Have you heard anything, Jennifer?
No, and I don't know what the holdup is, quite frankly. I was expecting it last month. So either you've got to re-crunch some data. Sometimes if they give some, incorrect math, they make them redo it all.
We do expect that Pfizer will go down too in the next few months too, down even more, maybe to age 5.
Yeah, we're thinking that might go down to 5 sometime in September and then down to 2 sometime in January. But that's just our guessing.
Yeah. Mary was commenting when we were talking about too much too soon about, yeah, this is a big deal with our foster kids or kids who are now with grandma and grandpa. That is huge. For foster kids, they, that parents then say, isn't that too many? Because, you know, you're having to give them 7.
You can't find the record.
But remember, you can't have too many vaccines in a given visit.
Right. And you know, with a lot of those foster kids or those kids where the records have been lost and they can't find them, a lot of times what we do is we'll give them everything they need on that first visit. And then we sort of give them some help on, okay, let's see if we can find a record. You know, we can help you. Here's some places where you can go find a record. And so that usually helps because sometimes if they just get given a little bit more time to find a record. So we'll go ahead and give them everything they need on that first visit and then give them some tips and tricks on how to find an immunization or something.
Yeah, and Donna had also commented on that too, to make sure that the grandparent is able to consent, which is a really important point. And I think that one of the things that we've heard at tips before is you know your families and you know that sometimes those, you know, children are, you know, with their biological parents sometimes and then go to grandparents for a period of time, and that's who's bringing them in. When you can get the biological parents to provide those consent forms for other family members and say who can consent if you know that grandparents are going to be coming in. There was one on the schedule which we're probably going to have to look up. Question presented in clinic today regarding MMR varicella. If varicella was given at one visit and patient returned for MMR 3 weeks later, do both vaccines become invalid or just the MMR?
So if they've both been given
3 weeks apart.
I believe the MMR is invalid.
That'd be a good one to ask the expert for too.
Yeah, let's ask the expert on that one.
Okay, we'll get back to you on that too, Lisa.
Yep. But you're stumping me today, guys.
No, it's because you're getting ready for vacation.
That is true.
Oh, you already got that one. How do we get the certificates for your staff? Have them fill out the evaluations and we'll make sure to get the certificates with their names on it, or you can email us. Oh. Some of these questions get answered after I read them. Maybe I'll start at the bottom.
So on the CDC site, it says the second dose that was given within the 30 days should be repeated after the recommended interval. So 30 days from the second dose that was given that was wrong.
So if you gave MMR first and you gave varicella 3 weeks later, you would then repeat the varicella 4 weeks after the varicella.
Correct.
Okay.
But in this situation, they gave varicella first.
Oh, did they? Yeah.
Mhm.
Oh, except that
Everyone knew it was 15, Macrina, for HPV.
yeah, we're gonna have to ask because now there's a new footnote that says you may not have to give it if it's been more than 14 days. So now we have to ask because now they just contradicted with their footnote.
All right. Well, ask the expert it is. Why does the other one that had popped up, Macrina, on our evals was why does it hurt so much?
Why does what?
HPV hurts so much?
I think it's just the ingredients in it and how it's made.
The adjuvant,
The adjuvant probably has something, is just a component of the vaccine.
yeah, and an adjuvant is added to a vaccine so that it kind of irritates the spot where the vaccine went in, so that your body goes, oh, holy crap, something's wrong, you better go check this out. Your immune cells there, which then make the memory to the disease using the vaccine. So it's actually intended to kind of irritate your arm a bit, just to send that alert out. So some of the adjuvants are a little bit more irritating than others.
So it sounds like for HPV, Men-B, and PCV13, those are the power adjuvants, huh?
Yes. Yes, those are definitely the ones that hurt a bit more.
If a patient has an adverse effect on the first dose, can they still get a second dose of a vaccine?
Oh, that would definitely be a provider call to find out exactly what the adverse event was. If it's an allergic reaction, probably definitely not, but that would be really take a look at the adverse event. And that would be a physician's call.
Okay. Yeah, and Jennifer, I give the Herdy vaccines last in there. I think a lot of people do that. Some people give the Herdy vaccines first.
So I give the Herdy vaccine first. I give the HPV first because I tell them this is the worst it's going to get. We're done. That's the worst it's going to get. Usually the MCV4 and the Tdap don't hurt that bad. And so you know what, my philosophy is to get the worst over, is to get the hardest thing done first. So let's go that way.
I think most people give the hardest one last.
I know. I would, you know what, whatever system works for you. I think that this is definitely one of those things where you have the most success, go for it.
Yeah. Yeah, for the little ones, they're saying if you give the one that hurts the most first for those little ones, it might be harder to get the other ones done.
Oh no, the little ones, I go the opposite direction.
Yeah.
Yeah.
Well, I've also heard from people they like to give HPV first because it's not required for school. So if they decide to not finish all 3 of those shots that they're getting, they kind of have to finish the other ones. So.
And also with HPV, you want them to stay with you a little bit longer, just in case there is that syncope. So normally I give it first because then they're sitting there and we're chit-chatting, we're giving the other 2 and we're talking about, so when does school start, who's your best friend, what's your favorite class? And so while you're doing all of that, you can actually get that patient to sit there a little bit longer before they run off.
We've heard that with COVID vaccine too, because the providers, are really trying to be sticklers about that 15-minute waiting period. So in some private practice settings, they're giving it first.
Right.
So they free up the exam room quicker.
Yep.
Because it's hard. I mean, we've heard that for years at TIPS in private practice. It's hard to get a patient, find a space for them to sit for 15 minutes.
Well, it's even hard in public health to find a spot for folks to stay for 15 minutes. And then, all you do is you say, well, if you'll sit in this little like post-vaccine area, but all you got to do is turn your head and they're gone.
Mm-hmm.
So that's why normally with kiddos, we give the COVID first. With, I give HPV first. Because at least I'm going to keep them a few more minutes than I would if I gave them last.
Anything else? All right. Well, I guess we'll see you all in 2 weeks. Thanks for staying on.
Thank you, guys.
Bye, everyone.